Okay friends, welcome to the next lecture in ABG series. Now we'll take from the last lecture where we left at metabolic and respiratory alkalosis. In this lecture we'll be completing the compensatory mechanisms followed by few examples of interpretation of ABGs. So before I go into compensatory mechanisms, few things which I want to you to know is, you remember a mnemonic known as SMORE. SMORE, S-M-O-R, means metabolic will move to the same direction. What moves to the same direction? pH and HCO3. So pH and HCO3 in metabolic moves to the same direction, but pH and PCO2 moves to the opposite direction in respiratory pathology. Okay, metabolic, pH and HCO3 moves to the same side. If pH is getting high, HCO3 will get high. If pH is getting low, HCO3 will get to the lower levels. The opposite is there with respiratory pathologies, wherein pH and PCO2 moves exactly opposite to each other. This is known as SMORE, S-M-O-R. So the second concept which I want you to understand is of delta ratio. It is very important, delta ratio. Whenever you encounter an ABG where there is a high anion gap, hagma, all the examples of mud piles, you have to calculate delta ratio. It is mandatory. And how to calculate? So what you do is you take measured anion gap, you subtract the actual or real anion gap, that is 12. From this you divide this by the normal HCO3, which and subtract the measured HCO3. From measured anion gap you subtract the actual anion gap, that is 12, and you take the actual bicarb and subtract the measured bicarb. This gives you a ratio. It can be either 1 or less than 1, it can be 1 to 2, or it can be more than 2. If it is 1, that means that ABG is purely hagma. That means if my delta ratio is coming out to be 1, I am dealing with only one pathology, that is high anion gap metabolic acidosis only. If I have something which is between 1 to 2, if the delta ratio is coming out to be say 1.6, that means I have hagma as well as nagma. I have two pathologies going on simultaneously. That means I have high anion gap metabolic acidosis as well as I have normal anion gap metabolic acidosis in the same patient. So here you add nagma in hagma. If it is more than 2, it means that with hagma you have metabolic alkalosis also. So you have two pathologies. You can have 3 pathologies also. Here we'll discuss it in subsequent lectures, but just by delta ratio you can tell whether I am dealing with purely high anion gap metabolic acidosis, or I am dealing with high anion gap plus normal anion gap metabolic acidosis, or I am dealing with high anion gap plus metabolic alkalosis. So this is the beauty of calculation of delta ratio. You have to do it in every patient who has high anion gap metabolic acidosis. In a patient who has nagma, you don't have to do delta ratio. In respiratory pathologies, you don't have to do delta ratios. Okay. Now we come to compensation mechanisms. See, our body's nature has made our body in a very profound way, in a very beautiful way, wherein slight change in the profile of acidity or alkalinity, I have some buffer systems. My first buffer system is this. Simplest equation. In my cells, we have a metabolism going on, CO2 production is going on, CO2 combines with water to give rise to H2CO3, which is a very weak acid under the influence of carbonic anhydrase, and there is a production, it dissociates into hydrogen ion and HCO3 ions. So this is a buffering system. Suppose my H ion goes up, so the shift will be like this side. If my CO2 goes up, the shift will be like this side. So this is a fast acting mechanism. This is a fast acting mechanism. It acts in minutes, but it is not a profound mechanism. Means it won't be able to give you a good correction of your basic pathology. It will try to correct it fast, but only for a very short duration of time and to a lesser extent. Then you have, when we talk of anion gap, what are anion gaps actually? Anion gap means organic acids. Organic acids. They are also acting as buffers. They are in our blood. So that anion gap 12 is organic acid. Okay. So that is a marker of buffering system basically. So apart from this, these are fast acting. We have some slow acting buffers. The slow acting buffers are kidneys. Kidneys take time, but they are good buffers. They will act in hours to days, but they act well. You can have a patient who is in chronic respiratory acidosis, right? So your kidney will do something to make pH well within normal range for that patient. So it's a long-term, chronic, robust compensatory mechanism. Our lungs also compensate by ventilating. So lung compensation is also fast compensation. So right, so blood buffers, lung compensation are fast compensators, whereas renal buffer or kidney buffer is a slow compensator. So suppose I have a patient who has metabolic acidosis. Metabolic acidosis. So I apply my equation, pH equals to HCO3 divided by PCO2. So what is happening in metabolic acidosis? Either there is increase in H ions or there is decrease in HCO3. So if I use this equation, pH is going down, the numerator HCO3 is going down. What should be the compensation to make this pH normal? The compensation should be a decrease in PCO2. If numerator also decreases in the same way as denominator, the pH will be same. If HCO3 is 2, PCO2 is 2, pH is 1. If HCO3 decreases to 1 and my body decreases my PCO2 1, the pH again becomes normalized to 1. So my lungs will hyperventilate, increase ventilation, and will decrease my CO2. This decrease in CO2 will reflect as my normalization of pH or near normalization of pH. Got the first mechanism? So it is in metabolic acidosis, the primary compensatory mechanism is lung. The PCO2 decreases, the denominator decreases, and my HH equation tells me that my pH will turn out to be near normal now. So this is the first mechanism. Now suppose I have metabolic alkalosis. The same thing. I have an increase in bicarb or decrease in H ions. So what should be done by lungs? Lungs should try to preserve CO2. If my PCO2 is preserved, again my pH will start traveling towards normal. So lungs will hypoventilate. lungs will hypoventilate so that my CO2 in blood increases. If CO2 in blood increases, it increases in the same direction as HCO3, pH near normalized. So this is a compensatory mechanism for metabolic alkalosis. So remember, when we are talking of metabolic acidosis and alkalosis, the compensatory mechanisms are primarily lungs, right? In acidosis, I will hyperventilate and there will be CO2 washout, and in alkalosis, I will hypoventilate and I will retain CO2. Similarly, suppose I have respiratory acidosis now. I have respiratory acidosis. For any reason, I have, suppose, polyneuropathy, and my drive from the central nervous system is not going to my diaphragm. So the pH is less, HCO3 divided by PCO2. So that means my PCO2 has increased. That means my PCO2 has increased. If I think HCO3 as constant, my PCO2 has increased, and that is the reason my pH decreases. They travel in opposite direction in respiratory problems. So the compensation now will be done by kidneys. What compensation they should do? Kidney filters both HCO3 as well as H ions. So kidney will try to preserve HCO3. If my kidneys preserve HCO3, my absolute HCO3 concentration increases in blood. So PCO2 and HCO3 are in the same ratio now, and my pH will near normalize. Getting the point? So you have HCO3 preservation and H ion excretion. So my kidney will secrete lots of protons or H ion in my urine, and it will conserve bicarbonate. This bicarbonate with HH equation will give a near normalization of my pH. Similarly, if I have respiratory alkalosis, my PCO2 is low. Respiratory alkalosis, my PCO2 is low. I am hyperventilating. So if I am chronically hyperventilating, my PCO2 is low. What will happen to my kidneys? They will conserve hydrogen ions and they will secrete bicarbonate. If I secrete bicarbonate or I have bicarbonate urea, my HCO3, absolute HCO3 value in my blood goes down. If HCO3 goes down, PCO2 is already down, so the net result will be near normalization of pH. So you see that we are using this equation everywhere, HH equation. In every compensatory mechanism, suppose you forget, so you just write down this equation and imagine the movement. You have to move your pH in the normalization. How will you move? You can just put these arrows and you will never fail in this exercise of compensation, right? You understood all the compensatory mechanisms? We'll do now some ECG interpretations, ABG interpretations, sorry. So I'll give you examples. We'll start from very basic examples. See, suppose example 1, my pH is 7.29. Well, before that, we should know what is the normal pH. The normal pH range is 7.35 to 7.45. The normal PCO2 is 35 to 45 millimeters of mercury. My HCO3 is 22 to 26 milliequivalents per liter. So this can be taken arbitrarily as 40, this can be taken as 24. You can have a patient where your pH is normal. That doesn't mean that patient doesn't have a problem. It means that there is a problem. Probably the compensation is good enough to make the pH normal. So just don't negate the ABG just by looking at pH. Look on all the parameters. So when we see ABG, we see pH first, then we see PCO2, whether PCO2 is driving my pH up or down. Then I see HCO3, whether HCO3 is moving my pH up and down. Then I calculate anion gap if I have metabolic acidosis and classify it into high anion gap or a low anion gap metabolic acidosis. If I have high anion gap, I calculate delta ratio. This is the minimum you have to do. Then you always see base excess also. What is base excess? Base excess is nothing. Just remember the value. It is from -2 to +2. Anything which is more than -2, more negative than -2 is metabolic acidosis. -3, -4, -6, -10. It means more metabolic acidosis. Anything which is more positive than +2 is metabolic alkalosis. Right? This is your base excess. What is base excess? We'll come to this in subsequent lectures. But just for the sake of interpretation, you should know that -2 to +2 is normal base excess. So yes, the first example is if pH is 7.29, PCO2 is 68 millimeters of mercury and HCO3 is 26. What does my pH tells you? It tells you there is acidosis. So first point you have to write it that this patient has acidosis. So I write acidosis. Now I look towards my CO2. Is it more? Yes, it is more. So my pH and CO2 are moving in an opposite direction. pH is decreasing, PCO2 is increasing. So the problem is respiratory acidosis. What is my HCO3? It is technically normal, near normal, right? Technically normal, high upper limit of normal. So compensation is not there, no compensation. That's all. Don't have to do anything else. So this is acidosis. Why I am using word acidosis before respiratory? There is a reason. If you say respiratory acidosis, you may tend to miss the second component. So you start with acidosis. Then you add respiratory component because there can be a metabolic component also. There could be a feature where HCO3 is 10, suppose. So that means now patient has respiratory acidosis as well as metabolic acidosis. There are two components which is they are contributing to development of acidosis, or rather acidemia to be precise. You have metabolic acidosis, you have respiratory acidosis giving rise to acidemia in blood. Getting the fine point? So use word acidemia first and then add the quality of that acidemia, whether it is respiratory or metabolic. This is a very simple example. First example. Second example. Suppose my pH is 7.49. PCO2 is 24. HCO3 is 22. So it is well beyond 7.45. So it is alkalosis, no doubt. Alkalosis. I see my CO2. It is less than 35, definitely. So my pH is going up, CO2 is going down. So it is respiratory alkalosis, no doubt. Clear? It is respiratory. What happens to my HCO3? Again, it is normal, 22 to 26. It's normal. So no compensation. If you have only this much, so this is the outcome. You can have other values also. You can get electrolytes also where you are calculating an anion gap. But once you have respiratory alkalosis, you are not calculating an anion gap, right? Third, suppose you have pH of 7.5, PCO2 is 41, HCO3 is 29, pH is 7.5, definite alkalosis, no doubt, alkalosis. but I see my CO2 now, it's not moving. So no respiratory component contributing to alkalosis. HCO3 slightly high, so metabolic problem. See, HCO3 and pH are moving in the same direction. pH is up, HCO3 is also going up, same direction, it's more, right? So it is metabolic alkalosis, right? Is there a compensation? The compensation should have been done by lungs, right? No compensation. No compensation. Clear? Fourth, suppose my pH is 7.3, my PCO2 is 60, my HCO3 is 29. 7.3 absolute acidosis, no doubt acidosis. I see my CO2 getting higher, so pH is going down, CO2 is going up. Problem is respiratory, so it is respiratory. HCO3 is slightly high, so I think there is a compensatory mechanism going on, but it is not a full compensation because my pH is not normal. So partial compensation. Partial compensation. So this is respiratory acidosis with partial compensation. Now I have pH which is 7.29, PCO2 which is 41.2, HCO3 which is 15. 7.29, is it acidosis, right? My CO2, it's absolutely normal, so it's normal. 41 is nothing, it's normal. Okay, we have to give some relaxation. We can't just because it is more than 40, we can't say it is a contributory factor. HCO3 is definitely less, so my pH is going down, my HCO3 is going down, moving in the same direction. Problem is metabolic, so it is metabolic acidosis. In metabolic acidosis, my lungs should hyperventilate and CO2 should wash out. It's not happening. So what does it mean? It means I am getting this patient in a very early stage. I have caught this patient ABG in a very early stage. Probably after a few hours, you will see that PCO2 has fallen. So suppose I ingest lots of methanol, and in that toxic period, my lungs are not hyperventilating. My ABG could be like this. But after say 12 hours, the HCO3 will change to lower value. It will compensate, right? If I have electrolytes, I should calculate an anion gap in this case, and then delta ratio also. Suppose my pH is 7.3, PCO2 is 30.7, HCO3 is 13. 7.3 acidosis. Now it's a tricky situation. My CO2 has gone down. My CO2 has gone down. What does it mean? Because as a convention, I follow this rule: first pH, then PCO2, then HCO3, then anion gap, then this. Remember, CO2 and pH will never travel with each other. They will travel in opposite direction. Okay. Sorry, I'm talking about HCO3. .7 HCO3 is. You see bicarb, it is very less. So it is 100% metabolic acidosis, but there is a compensation by our lung. They are hyperventilating. So it is just one step ahead from last example. So this is metabolic acidosis with partial correction. A full correction would be near normalization of my pH. So it is partial correction. Suppose pH is 7.14, PCO2 is 68, HCO3 is 15, base excess is minus 9.7. So 7.14, this is acidosis, no doubt. PCO2 is high, going in opposite direction. So it is respiratory acidosis. My HCO3 is also low. So it is metabolic component also, plus metabolic acidosis, which is confirmed by a negative base excess. If I have a negative base excess, it confirms presence of metabolic acidosis. So there are two pathologies contributing to one acidosis, respiratory as well as metabolic. I hope you are following it, right? We'll do 2-3 more examples. They are bit different. Suppose my pH is 7.3, PCO2 is 33, HCO3 is 10, sodium is 135, chloride is 113. So it is acidosis, no doubt. My PCO2 is going down, so probably this is a compensation going up, and my HCO3 is less, so it is metabolic. So it is metabolic with partial compensation. Partial compensation. Now I have to calculate an anion gap in this. So how do I calculate? 135 minus 113 plus 10. So it is 123, 12. So anion gap is normal. No need to calculate delta ratio. No need to calculate. It is a normal anion gap metabolic acidosis which is partially compensated. Suppose my pH is 7.21, PCO2 is 22, HCO3 is 8, sodium 137, chloride is 80. 7.21 acidosis. PCO2 going down, hyperventilation. HCO3 less, same direction. So it is metabolic. Now I will calculate anion gap. It is 137 minus 80 plus 8. So it is 55. Very high anion gap. Very high anion. Now I will calculate the delta ratio. Right? 59. Sorry. Now I will calculate delta ratio. How do I calculate delta ratio? Delta ratio is 59 minus 12 divided by normal HCO3 24 minus measured 8. So it is 47 divided by 16, somewhere around 3. The measured anion gap, you subtract 12, which is the normal anion gap, and 24 is the normal bicarb. You subtract the calculated bicarb in your ABG. It is around 3. What does it mean? It means with a high anion gap hagma, you have a metabolic alkalosis also in this. So without delta ratio, you will never capture this concept of duality. So you have a dual diagnosis in this. You have acidosis, which is metabolic, plus metabolic alkalosis also. Mind you, by looking at this picture, you will not get metabolic alkalosis. Just by delta ratio, you are getting metabolic alkalosis. Suppose this delta ratio would have been 1.5. That means with metabolic acidosis, which is hagma, high anion gap, I am also having normal anion gap metabolic acidosis in the same equation. If this is 1, that means only hagma, right? So I hope these examples will serve a purpose. You will be able to do basic ABG analysis by yourself now. Now few words regarding VBG. You know, in emergency settings, VBG can be done safely. It's less painful to the patient, less troublesome, and demands less technical expertise. Anyone can do a VBG. In VBG, you know, pH and HCO3 are nearly similar to your ABG. Your pH is probably 0.02 to 0.04 less as compared to your ABG, right? Whereas in your HCO3 is 1 to 2 milliequivalents more than your ABG. So this is not much of a difference. So in VBG, suppose you are dealing with a patient of diabetic ketoacidosis, you can very well order a VBG, because in diabetic ketoacidosis, these are the two parameters you are more interested in, your bicarb and your pH, not in your PCO2 and PO2. But if you have a respiratory pathology going on, you have respiratory acidosis, you have respiratory alkalosis, the problem with this VBG is it is not a good marker for your PO2 and PCO2. There is a high variability. Suppose in ABG the PCO2 is 44, in the same ABG PCO2 can be 68. So very difficult to ascertain the normal value. Similarly for PO2, here it is 80, it can be 64. So there is a wide variation, wide gap. So whenever we talk of VBG, we are talking in metabolic disturbances, wherein we are interested in pH and bicarbonate. When we are interested in PO2 and CO2 values, we order ABG. So I think we finish this lecture now, and in next lecture we will do metabolic acidosis in detail. Thank you so much.